We'll start now the 14th scientific session by Professor Flavia Andrew. She will give us a talk about antimicrobial resistance and the possible role of microbiota.
So good afternoon, here I am again. You didn't get rid of me yet. Okay, so as you say, the title of this talk is Rational Use of Antibiotic and the Role of Microbiota in the management of antibiotic resistance. So because we choose rational use, because generally we have an irrational use of antibiotics, because the average proportion of children in hospital setting who receive at least one antibiotic is going between 33 to 78%. That means that out of 10, 8 children that come into the hospital receive antibiotics. And antibiotics are prescribed during approximately 20% of pediatric ambulatory visits. So no matter if they are in the hospital setting or in ambulatory setting, they receive antibiotics. Moreover, more than frequently, the antibiotics are administered in children who suffer from viral infection, so non-infection disease and other cases of broad spectrum. So antibiotics are given to children who suffer from infection for which narrow-spectrum drugs are indicated and recommended. And so sometimes you are using a broad-spectrum antibiotic. And many children receive antibiotic prescription indicated as an incorrect total daily dosage or fraction or for a period of time significantly longer than needed. So what is the consequences of this irrational use of antibiotics? There is an increase of drug-related adverse event. There is an emergency of multi-drug resistance bacterial pathogens, so this antimicrobial multi-resistance. There is an increased incidence of Clostridium difficile infection and a negative impact on the microbiota, and we heard before how much is important the microbiota. So the antibiotics, we need antibiotics because antibiotics target the essential process of bacterial process. So they go into the bacteria and they just stop the replication of genes because the bacteria produce some protein. So the antibiotics can act in a different pathways, in a different step of the pathway. So the proteins that the bacteria produce sometimes are the target of the antibiotics. But the antibiotics fit into the target's protein of the bacteria like a key in a lock. So different key fit in a different locks. So different antibiotics need different proteins, so that's why we use different antibiotics for different bacteria, because the proteins production from the DNA of the bacteria needs different antibiotics to act. It's just an example here. For instance, ampicillin, that is the most used antibiotics, binds into a tiny pocket in this target protein, as you can see. If it fits exactly like a key in a lock. This is a stereotactic reproduction of ampicillin fitting into the protein of the bacteria. So the bacteria are a live microorganism, and so they want to rescue themselves from the antibiotic. How can the bacteria proceed in this? They target resistant, they have the enzymatic degradation, and also the efflux pump. What means exactly this process? So every antibiotic targets some pieces of machinery in the cells. So penicillin targets the machinery that makes the cell walls. The bacteria's DNA sequences can be changed. So this results in the change of shape of the machinery. Then the antibiotics cannot bind anymore, and so the enzyme can still do its job. So they change the shape of the protein, so the antibiotics cannot fit anymore. So if they change the lock, so key, we need another key. So some bacteria have also enzymes that can modify the antibiotic shape. So it's not important only to change the protein shape, but also the antibiotic shape. So enzymes can modify the shape of antibiotics, so the antibiotics don't work anymore. So change the K will not fit in the lock. Change the antibiotic, it not will fit in the protein in normal binds too. So also the efflux pumps of the antibiotics, they just start to pump out the antibiotics out from the bacteria. So there are proteins in the cells that can act like a pump in the bacterial, of course. Pumps are small molecules in and out of cells, and some can pump out the antibiotics. So the antibiotics resistance came from different pathways. Every bacteria have different pathways. So evolution and selection and transfer of antibiotic resistance genes from another bacteria. Evolution selection is the most important. Bacteria are representing the evolution in nature. So they still remain because they have the ability to change themselves and to get resistance to the antibiotics. So the most important is this gene transfer from a bacteria to another. So there are many ways to do this transference. So a phage, that is a virus that attacks bacteria, that can be transfers the gene to another bacteria, and conjugation, the transfers of genes from bacteria to bacteria. So this change the DNA, change the protein, and change the lock. And so these are the bacteria, the weapon of the bacteria. And so how can we fight back? So we use antibiotics, the bacteria change, we don't have antibiotics anymore. And so we don't have any more antibiotics. So now this is a main issue. Pharmaceutical companies are studying and studying and studying, experimental, billions of euros, but they cannot find any other new antibiotics that can kill the bacteria. So there are some diseases that are multi-resistant. So we are in some, especially in the adults, you have an hemoculture that you have almost all the antibiotics known that are resistant, bacterial resistant. So you don't have any other weapon in your arm. And so look at this. The main problem is the shortage of antibiotics, the increased rate of infection and the shortage of antibiotics. And this is a serious problem for the society. So antibiotics is a very complex system because it's a shortage of antibiotics, it's a doctor-patient. People died for infection, get it into the hospital because of this multi-resistance drugs problem. So how can we have the strategy to reduce the antimicrobial resistance? Of course, there are different settings, hospitalized setting and community setting. What can we do for antibiotic use in hospital setting? There are a lot of strategies. I just listed some. When we are dealing in the hospital, so we have to review and analyze antibiotic use after they've been prescribed. So we have to go to look in the history of our hospital, which antibiotic we have been used in the period back. Reach consensus on the antibiotic use before they are prescribed. So know the problem that must be considered for rational use of antibiotics. Prompt initiation of antibiotic use when indicated, so we don't have to wait. Avoiding the use of antibiotics for condition not due to the bacteria infection. Choose the first and second line drugs for the demonstrated or supposed bacterial etiology responsible for the disease that require treatment, not choosing the last molecules we have. We start with the first molecule, the first line drugs. So we have to identify the proper dose and fractioning and duration, because also this, using wrong doses, wrong duration, and switch from intravenous to oral administration according to the patient disease. We have to be very careful. Choose the condition of which antibiotic prophylaxis is needed, and methods to rationalize antibiotic therapy. So education, guidelines, handbook, multitask, conference. So it's extremely important. So antimicrobial resistance needs a multidisciplinary approach and a stewardship team. obtaining administrative and leadership support, continuous and transparent monitoring of antibiotic use. We do need to have, a register to know which antibiotics we are using. I'm talking about hospital setting. Adequate use of diagnostic tests, including, of course, point-of-care tests, and knowledge of local resistance rate of different pathogens, because you know that it's a local resistance rate. So we can just summarize the 4 moment of antibiotic decision-making. Does my patient have an infection that requires antibiotics? So I go for diagnosis. Have I ordered appropriate culture before starting antibiotics? What empiric therapy should I initiate? What a day or more has passed. Can I stop antibiotic? Can I narrow therapy, change from IV to oral? So we have to consider all this. What duration of antibiotic therapy is needed for my patient diagnosis? So these are the 4 main points in deciding the strategy. And of course, there are European guidelines. Of course, I took these from prudent use of antimicrobials in human. Of course, in the US, there are even more than this. But what this antibiotic stewardship program say, that this stewardship program are the best led by infection disease physician with additional stewardship training. But what means stewardship? So if we go on the definition of steward, is one who manages another property, finances, or other affairs. And what about stewardship is the occupation of being a steward or a custodian. So the activity or a job or protecting and being responsible for something. So we need to be responsible for the use of these antibiotics. So antimicrobial stewardship means coordinate intervention designed to improve and measure the appropriate use of antibiotic by promoting the selection of the optimal antimicrobial drug regime, dose, duration, and therapy, and route of administration. So this is the point of stewardship of antibiotic. Know perfectly the kind of antibiotic, the dose, and the timing. So what is the importance of good bacteria? I showed you before how these microbes colonize the intestine and commensal protects against disease. So whenever we use antibiotics, we destroyed our commensal bacteria. So what we can do, and if we don't take care properly of this, maybe we can also have a possibility to transfer the resistance. But now they are starting to manipulate the microbiota and to use probiotic to stop this process of drug resistance. This is one of the last publication in Frontier of Microbiology. I skipped the time, but it's 2019. And there was a protection of this gut microbiome for the beta-lactamase cephalosporin resistance. And of course, every one of you are aware that the nosocomial diarrhea in children comes from the improper use of antibiotics. So this is a position paper from ESPGHAN committee, ESPGHAN working group of prebiotic and probiotics. So whenever we use antibiotic in the hospital setting, we just supplemented the children with Lactobacillus GG or Saccharomyces boulardii, because this is protecting the commensal flora, so the commensal flora will protect against also antibiotic resistance. And of course, this is the main problem, the Clostridium difficile infection, and this was the position paper of working group of ESPGHAN just published a couple of months ago, that is extremely important to recognize the Clostridium difficile infection. And of course, this is an algorithm I will not go, but whatever it is, we have to look for C. difficile and be carefully in using antibiotics. So what about the antibiotic use in daily practice for community setting? So there's another story, of course. So first of all, the common sense golden rule. I put it in bracket because there is no guideline written, but some only suggestions. So do not use antibiotic if you have suspicion that is viral infection. Try to use a simple and quickly method for diagnosis, and use the antibiotic stewardship, as I told you before, time, dose, kind of antibiotic. But more than ever, I would say prevent the infection. And as all of you know, being a pediatrician, that the 80% of the immune system of the baby can be indirectly linked to the gastrointestinal system. I showed you before that the gut-associated lymphoid tissue is the most larger lymphoid organ in the human body. So whenever is challenged the immune system, particularly in the children gathered in groups or in the daycare center, we have to take care of the mucosa, intestinal mucosa. We have to take care of the microbiota of the baby about this immune function and protecting this microbiota and using, like I show you this, in using a commensal bacteria or a prophylaxis or maybe a prevention with supplementation of good probiotics that have an efficacy and that have been shown to prevent infection, that we can act on this part of immunity of the gut-associated lymphoid tissue just to go on and protect the general immune system. And this slide I'll show you before, commensal bacteria are extremely important to create a eubiosis that can drive the process of immunity through the gut-associated lymphoid tissue to the general immune system. So what are the take-home messages I can say? That we need to develop a multidisciplinary pediatric antibiotic stewardship in hospitalized and community setting. There are a lot of rules already written for European and US. We have to take care of the child immune system and the child gastrointestinal microbiota and use as much as possible prevention strategy. So thank you very much for your attention.
Thank you, Professor Dr. Flavia, for this excellent presentation. Is there any question for Professor Dr. Flavia? Okay.
If we had to use antibiotics for a neonate,
sorry, I cannot hear you. Just speak a little bit louder.
If we had to use antibiotics for a newborn infant, and as you said, this will affect the normal commensals, when would you expect the return of the normal commensal to normal? After how long?
Yes, of course, when we use antibiotics, we will affect completely our microbiota. I show you also in the previous lecture. So that's why there are these position papers that whenever we have antibiotic use, we just can supplement with probiotic, because to restore the normal flora after use of antibiotics, you maybe need 1 month. And during this period, you can have the possibility that pathogens can grow, like Clostridium difficile, and you never get rid out of the Clostridium difficile. Is very difficult infection. So we strongly advise to use probiotics together with antibiotics. Yeah.
Is there any possible question? Okay. Thank you very much, Professor Dr. Flavia. Thank you.